percent is the normal fat, and a person uses nearly 2 to 4 units of insulin to have this good blood sugar of 90. But a person with fatty liver, where the liver cells are swollen, may need 20 units of insulin every day to have a blood sugar of 90. So remember, it is not blood sugar alone, it is the amount of insulin which determines insulin resistance and all complications. Fatty liver means more than 10% of the liver is having fat. Obesity, extra calories, or genes determine this. The fatty liver can progress when the white cells kill these fat containing cells, as a result producing hepatitis, which is red in the blood by increased ALT, healed by scarring, leading to stage 1, 2, 3 fibrosis. Stage 4 would be cirrhosis, and about 2 to 12% can develop liver cancer. Today, of 100 liver cancers in India, 39% are in diabetics. Diabetes is a liver disease because extra insulin being produced over periods of time. The liver fat also is spilled into the blood, so the person may have high cholesterol, triglyceride, blood pressure, heart, kidney disease, bone cancer, stroke, gallstones, and PCOS. So, fat in the liver is the major problem. It frames and changes your body, and it's a top public health issue. To summarize, obesity or overeating and inactivity raises the risk of diabetes by 4 times, and the fatty liver is a major player. It also adds to high lipids, hypertension, dementia, Alzheimer, low testosterone, uh, virality, heart disease, stroke, and increases the risk of cancer. Therefore, we must catch it early. Liver fat precedes development of diabetes, heart disease, blood pressure, NCDs, non communicable diseases by 15 to 20 years. So we used to call it simple fatty liver, then NAFLD, then it changed to MAFLD, metabolic dysfunction associated fatty liver disease, which I still feel is the best term, and then was changed to MASLD, metabolic dysfunction associated steatotic liver disease. 1 in 3 Indians have fatty liver, and it can easily be diagnosed. All those who are pre-diabetic, above 5.7, or diabetics, suspect fatty liver. Those who are overweight or obese, BMI above 23, suspect. Those who are lean, but their waist in female is above 80 and in male above 90, remember this, I'll show you. High blood pressure, high TG, or a family history, suspect. 8 out of 10 diabetics in India would have fatty liver, and 2 out of 10 diabetics, that is 20 million, 2 crores, will have cirrhosis. The MASLD diagnostic criteria require a fat on imaging or on biopsy with cardiometabolic risk factors, then you call it MASLD. And these in adults, as I said, BMI in West it is about 25, high sugar, BP, TG, and low HDL. And pediatrics are different. Just to tell you, low HDL, 72% Indians have HDL, which is less than 40. Therefore, if you use one single criteria with fat in the liver, most Indians will have fatty liver. Therefore, MAFLD requires two criteria, while MASLD requires one cardiometabolic criterion. The risk factors include, of course, unhealthy diet and the genetics, the gut dysbiosis by changing your food to an inflammatory type of food with a lot of fried and high sugar food. They change the bacteria. Then type 2 diabetes once develops adds visceral obesity, insulin resistance, low adiponectin. They all lead to development and progression. Of the initial stages, about 40% can reverse. But once it starts developing F0 to F1, the reversal rates goes down. F0 to F1 about 30 to 35 years. But if you detect somebody who is already stage 2 fibrosis or stage 3, you need to be careful. They can develop early onset liver disease, cirrhosis, and complications. So, self test, family or self, anybody has obesity, diabetes, BP, heart disease, liver, cancer, polycystic ovary, suspect. Weight, height minus 100, 170 should be 70, and in a female, height minus 105. If there is a family history, reduce 5 kilogram. Waist, I already said, ultrasound, abdomen, fibroscan, ALT above 30, high cholesterol or TG, and high blood sugar. Now, this I wanted to show you. These are two individuals. Both have BMI of 22. He is healthy, he is unhealthy. He has good muscles. Red color is muscle. Green subcutaneous fat is less in this, and visceral fat is less blue. Here you can see that the subcutaneous fat is more and visceral fat is much more. 107 compared to healthy, and visceral adipose tissue nearly 5 times or so. This is seen by a simple body composition analysis. Here is a guy whose BMI is about 25, 26, looks like normal, should not be worrisome, but his percentage body fat is 40%, and his muscles, left leg, right leg, everything is poor. So if you do total, he is 7 kilogram less muscle and about 18 kilograms of extra fat. So, waist is the most important part where you have bad visceral white fat. Fibroscan picks up the stiffness as well as fat. If the liver fat is less than 238, it is good, but above that it starts. Anything above 260 will be high, and this patient has 306, means more than 66% liver fat. And his stiffness should be less than 6. Anything above 8 is grade 2 and requires attention, and therefore this patient has grade 2 fibrosis with more than 66% fat. So, how do you investigate an approach? So, patient comes, you will ask two or more cardiometabolic risk factors or diabetes or imaging has steatosis and you have excluded alcohol. You will do CBC and LFT simple. Wish to calculate FIB4, which needs age, AST, platelet, and ALT done by this test CBC LFT. If it is above 2.67, then refer to a specialist. If it is less than 1.3, you call this patient once in 3 years. If it is between 1.3 and 2.67, it is a gray zone indeterminate. Then you do fibroscan, which if between 8 and 12 will say yes, this guy may have fibrosis and he may need a liver biopsy or so. There are more advanced diagnostics. You can use FAST score where you have fibroscan plus AST or MRI, proton density fat fraction, which if it is more than 10 also causes worry for us. How do you treat MASLD or MASH? What are the new options? First, prevention and lifestyle modifications. Two, change your attitude. Don't say he has it, I have it, so what? So people who have a BMI of 25 to 27, this is Western, I would start with 23 onwards. Lifestyle and behavioral changes, eating, activity, psychological intervention. Anything about 25 should make us have low calorie and very low energy diet. And then anything above, I would say 27 or so, or fibrosis, we have to start using some kind of medicine. And above 35, certainly bariatric, and above 30, maybe balloons. So, exercise means 30 minutes after sweating. And my suggestions for simple memory: don't count steps, count miles. Don't use lift, which is for patients. Pick your own luggage, keep your AC at the lowest, and have a waste zone in the college school where weight and waste can be measured. Also, the government should build gyms so that people can get in public this. So I would like your country, your state to do much more. Green kitchens like this, you will have decrease in MAFLD, body weight, insulin sensitivity increases, LDL go down, biochemistry improves, body weight and systolic BP improves. Remember, metabolic equivalent of task when somebody is resting is 1, but exercise should be that you reach a MET of about 10. I don't have time, and sedentary behavior is to be avoided. Body composition, you must know. Remember to lose central obesity, increase lean body mass by muscle increase, bone mass must be increased, and overall body mass 7 to 10% should be decreased. All these are done not for publicity, just to tell you, are given in a book I wrote. And the whole idea is that you should say health is not given, health has to be earned. Now I go on to newer therapies for MAFLD or MASLD. Basically, we have three areas of work. By thyroid, we burn more of the hepatic fat as well as some amount of metabolic fat anywhere else. Second, we use lipolytic agents like liraglutide, semaglutide, and many more I'll show you. They would have enhanced lipolysis, fat oxidation. And the third group of drugs is FGF21 analogs, which in a way stimulate how the distribution of fat and metabolism in cells is done. Let's start with resmetirom, a drug which has been approved. Normally, the T4, which has come after the TSH has stimulated, and the enzyme DIO1, it converts T4 to T3. However, in liver disease, DIO1 enzyme is less. Because of this, conversion from T4 to T3 does not occur. Moreover, there is a DIO3 which is increased, so T4 is now converted to reverse T3. So there is a state of intrahepatic hypothyroidism. When you give drugs like resmetirom, they will increase the intrahepatic T3 levels. In this study, resmetirom was given in patients with NASH and liver fibrosis. 80 and 100 milligram showed significant benefit in reducing fibrosis, and also there was no increase in or worsening of fibrosis. So one stage improvement was seen in about one-fourth of the patients. No difference in 80 and 100. So now the standard dose is 80. There are minimal side effects of diarrhea, nausea, and others. And this has been approved by FDA and is also available in India by some companies. The additional benefit, I am showing you some earlier trials, it decreases LDL, ApoB, TG, and also might reduce fibroscan values, that is fibrosis, and also some fat values. The current guidelines clearly say if a patient has got a fibroscan between 8 and 15, you may not need a biopsy and you can start in this patient semaglutide or resmetirom. If the stiffness is between 15 and 20, F3, F4, well, in this patient, you might need a liver biopsy. And if the patient is above 20 or MRE above 5, this guy may have cirrhosis with portal hypertension, don't use in them semaglutide or resmetirom as per protocol. The incretins are molecules which are released once the food goes in, and therefore, here I will show you that the food comes in and several incretins GLP-1 and GIP they are released. They will also act upon several tissues: adipose, pancreas, brain, kidneys, heart, and vasculature. You know about incretins being internal medicine people. What incretins will do on liver and the rest of the body is clear, that they will reduce the lipid content, increase glycogen flux, and improve mitochondrial turnover and function. And they involve and improve multiple organs, so they are good for uh, cardiovascular, kidney, liver, and metabolic dysfunctions. This study, called the Essence study, was the first where semaglutide was used, and in this, compared to placebo, semaglutide was able to do resolution of fibrosis in about 62% compared to placebo of 34% or so. The adverse effect, of course, were there: nausea, diarrhea, constipation. And nowadays we know that people do not tolerate this. Vomiting, discomfort, bloating are very common side effects of this drug. There are several of these. Semaglutide, I showed you the Essence trial. Then tirzepatide, which is now running the phase 3. We are all part of it. It has a good resolution, and I think it has a improvement into the metabolic, liver, as well as body weight reduction. So tirzepatide is a good drug, and Monzaro is the name. I think it is available now. Survodutide, but not for liver disease as yet, but for weight loss it is used. For liver disease, still it is investigational. Survodutide is undergoing trial. It is GLP-1 plus glucagon. It is GLP and GIP, both incretins. Here it adds glucagon, and it has very good safety. Several trials are going on, still investigational. And pemvidutide, another phase 2 trial drugs, and now there are many others. It also has MASH resolution. The third group of drugs, first was thyroid hormone beta agonist, then incretins, and now FGF21. So naturally, FGF21, which is produced in the body, is broken down very fast in very short time. So you need to have long-acting FGF21 available, and this FGF21 increases insulin sensitivity in muscles. It also increases insulin sensitivity in the liver. It helps in the adipose tissue, increasing sensitivity, and pancreas and the liver. Lipogenesis and lipotoxicity is reduced. So it has multiple functions, and in my mind, it's one of the most promising drugs, and it is being evaluated. The drug, when given as pegozafermin, this was found to have in a dose of 30 and 44 milligram, that it reduces, improves the NASH without its worsening in about 30% or so patients. So it is a good drug, and it can be given weekly or every 2 weekly. The other drug which is undergoing trial is efruxifermin. It is given even in cirrhosis patients who are compensated. In these groups of patients, 28 or 50 milligram dosages was found to reduce the fibrosis at 36 weeks in both 28 or 50 milligram dosages. There were adverse events, but mainly diarrhea and nausea. So I summarize as of today, and this is a slide generated by AI. Diet and physical activity and exercise remain the major players. Management of liver disease includes the GLP-1, which we are using, dual GIP and GLP-1, tirzepatide, SGLT2 inhibitors, they are very weak. I do not think they work much, maybe 1% fibrosis regression. Pio, very poor. Now, vitamin E is not needed. Resmetirom, yes, it can be taken in. And advanced disease, we of course have. Obesity, type 2 diabetes, dyslipidemia, they require management as per their protocols. Metabolic endoscopist will like to put in balloons, different types, shapes, and sizes. They can do the remodeling of the stomach by reducing the size, and ESG is one of the easiest and good method of doing. You can also put in the balloons in the duodenum. You can resurface by putting an endo barrier and others. So the intragastric balloons have been used generally in non-cirrhotic, although we published they can be used in cirrhotics, weight loss, FDA approved. Sleeve gastroplasty also causes weight loss. It is good. Generally, we would prefer first balloon, then ESG, or after GLP, GIP, then only use ESG. The bypass is probably not very good for liver patients, and mucosal resurfacing is still investigational. I'll summarize with a concept for future. Why to decrease fatty liver? Surely to reduce the incidence of diabetes, cardiovascular and cerebrovascular diseases, and in fact all NCDs. This program and this concept was proposed to the Government of India, which included MASLD into the national program. And 2021, we are now 5.5 years ahead, and this gave India the number one status in the world, and only followed by UK. We started this program in 8 states starting in 2023, and then now there are 15 states which have done till 2026. And I want to see this photograph clearly. On June 1, 2025, this program was launched in Madhya Pradesh, and by October, they had done 11.8 million. And the way they did was a village worker would just do the waste and wait. So this is the data of 9th of September 2025, 3 months and 7 days later. They screened 1.18 million lakh people, and they were able to say males 15% had more waste, female have 17% had more waste. And BMI picked up 11% of the rural, but waste picked up more. So I think a combination of waste and weight is the best way for our country. And I suggest that Karnataka and API and whoever organizing should take up this as a simple method. Karnataka is lagging behind in this. My carry home message is liver diseases, both in general population, in diabetics, and in obese, are very common. So, every diabetic, liver disease, every obese, consider liver disease. So, screen all of them. All those who have metabolic problems, dyslipidemias, polycystic ovaries. Two-thirds of diabetics have fatty liver. Stratify them. You may use a new nomenclature. I've used the old one because people in general understand. Stratify those who have a raised ALT means active liver involvement. Liver stiffness is 8 or above. Assess them. Above 12, certainly refer. Weight loss of 10 and diet, exercise, and coffee are important. The drugs available to me, the cheapest is metformin. Saraglitazar, available and approved, good drug. Semaglutide, resmetirom, survodutide. Endobariatrics, of course, can be done. But first, all of us physicians have to change and then lead the change for reduction, detection, and treatment of fatty liver disease. Thank you for your kind attention.
Thank you, sir. Thank you. It was a wonderful deliberation as usual. Thanks for sparing your valuable time. Few questions from the audience, kindly take. Hello, sir. This is Dr. Shivanand Patel, sir.
Hello.
Hello, sir. Sir, wanted to ask regarding resmetirom treatment, sir. Actually, before that, you said that liver biopsy is required in these patients. Sure, because most of our patients may not. I mean, if they know, if they refuse, so can we?
Yes. They generally, I also try and get a liver biopsy done, although maybe 50-60% only agree. The idea is to know the activity, but you can use it as per the guidelines F2, F3, anything above 10 fibroscan repeated twice. I think you can use resmetirom in that. Once is not good enough, but twice you should do it.
Yes. And what about lean NASH, sir? What lifestyle modification should we?
Very good question. So you have to get the visceral fat out, and for that, lot of abdominal exercises. And I think you can use is resmetirom if it is F2, F3, and metformin causes weight loss, but you can use it because 3 to 5% weight loss is required. So combination of metformin, resmetirom, even in lean NASH, and of course change in lifestyle is what we need. But we don't have any specific drug as of now.
Any question from the audience? So regarding Met ALD, sir, like those who are taking alcohol along with the who are
Uh,
obese and diabetic and who are taking alcohol in a maybe around 40 to 60 grams. So can you just enlighten us about the management of?
Yeah, I did not purposely touch MAT-ALD, but it is a very common thing. Most of the patients with alcoholic liver disease have metabolic risk factors, and therefore MAT-ALD is common. We just completed a large study of 470 patients. MAT-ALD is more severe than pure ALD, and 40 to 60 grams alcohol, even if the patient says maybe he is drinking more, the fibrosis progression is about 2.7 times faster in MAT ALD. So, a liver biopsy in them is advisable to see what is the contribution of alcohol and contribution of fat or obesity. You should also test the alcohol by doing a PEth test, which is available most places now. So, PEth test, confirmation that he is drinking alcohol, and identifying how much is the damage by alcohol is important. And if he is not drinking alcohol, let's say for 2-3 years, then we would treat him simply as MASLD or so.
Yes, sir. If patient is detected to have fatty liver, sir, should the family members should also be screened for fatty
Yes.
liver or should?
I wish this is a very good question. Every family member should be screened because the genetic basis of PNPLA3, the TM6, as well as HSD and PCSK is very common in India. So every family member must be screened for fatty liver and warned, especially children, because the walking gene theory, if the father or mother has got disease at 50, the children might get it maybe 10 to 15 years ago. And every gallstone patient must also be, I forgot to mention, because gallstones are cholesterol stones. So every gallstone patient and the family must be screened.
Thank you so much, sir, for the
Thank you.
enlightening talks.
Thank you.
Thank you very much, sir. That was an outstanding presentation. Your insight into changing concepts of fatty liver disease and MASLD have been truly enlightening. On behalf of Dr. S.K. Sarin, sir, I would request Dr. Sangram, sir, to kindly take the moment. And I would request the chairpersons to give the moment. Thank you, sir. kindly request the chairpersons to be seated for the next session. Our next speaker is recognized across the world for his extraordinary contribution to gastroenterology and therapeutic endoscopy. It's my honor to introduce Dr. Nageshwar Reddy, sir. Dr. Nageshwar Reddy is one of India's most distinguished gastroenterologists, an innovator, educator, and researcher whose work has transformed digestive healthcare. His contribution to advanced endoscopy and medical innovation has earned him national and international recognition. Today, he joins us virtually to speak on artificial intelligence and innovation in hepatology. Sir, it's a privilege to have you with us. May I request the technical team to start the virtual meet?
Good morning, friends. I'm extremely glad that the Karnataka AP Association, the Gulbarga branch, is organizing this conference on MASLD and MASH. In fact, this is extremely important nowadays because the number of patients who are coming with this problem is increasing, and not only for gastroenterologists, hepatologists, but even for the physicians. I think the largest number of patients who are coming with this in the outpatient is patients coming with this type of problem. Also, metabolic syndrome being a part of this. Of course, diabetes, obesity, dyslipidemia, metabolic syndromes, and all form a group of patients who require specialized treatment. In addition, now we have a lot of new drugs which are coming in both for liver treatment, for fatty liver, for MASH, and also for the whole metabolic syndrome itself. We are in a very exciting period now, especially for the physicians. I think it becomes very important because we can make a difference in our patients' lives now. When Dr. Sangram Biradar, who is a very close friend of mine for several years, told me about this conference, I was not only excited, I wanted to be there physically to participate in this and also interact with all of you. But unfortunately, I had a commitment in Rome, which I had to be there, and that's the reason why I couldn't make it to this meeting because of the problem with the flights. Anyway, I think as I see this, there are very important topics that are coming on and some leading speakers. My talk is going to be an artificial intelligence in treatment of MASLD and MASH, and you can see a lot of advance in this area. Some of this is still developing, but I think we're coming to a point where we can use these advances very well. For example, now in evaluating patients with MASLD and MASH, we don't have to go for a fibroscan. Using simple biochemical tests and an algorithm that we developed in the AA department, we can give a very accurate diagnosis of steatosis and of fibrosis. We're going to discuss all this in my talk, and hopefully it will be useful to you. Thank you very much, and I'm sure you'll have a very good conference.
So I've been asked to talk on AI in hepatology. About 5 years back, I was a total disbeliever in AI. I thought human intelligence was much more important than artificial intelligence, and that we're sort of exaggerating this AI business. In the last 5 years, I've become a total convert into AI, using it not only in clinical practice, but also administration and so on. So I think this is an extremely important area that we are in, and I think this is something that at least the basics everybody should know. So I'm not an expert in AI, but I know how to use AI tools like ChatGPT and so on. So when I was asked to give this talk, Mithun told me give this talk, so I went into ChatGPT and said, what should I talk on? He said, you got 15 minutes, very short, but kindly this is the headlines, and told me, so I'm going to structure my talk basically on what it said. And finally it said, shall I make the slides for you? I said, no, I'll do that myself. So I followed exactly what ChatGPT said. The only thing I didn't follow was ChatGPT said, these are doctors stupid, don't go and talk all sorts of technical things. They're not engineers. But we can't avoid technical jargon when you're giving a talk like that. So I'll give you some basic, very simple things before we go into the actual hepatology part. So Alan Turing was the father of modern AI. In fact, he was responsible for deciphering all the codes that came from the German ships in the World War II, and that's how it started. The word artificial intelligence was first used in 1956 at a conference at that time. And then, and even now, we actually don't know what it means. It just means that the machine is as intelligent as a human being. For the next 20 years, there was a winter of artificial intelligence. Nothing happened. And in 1980s, machine learning came, that was okay. It was only in 2000 that actually artificial intelligence took off when deep learning came. Now, deep learning, or CNN as we call it, is a situation where you can give multiple feeds to a machine. It goes through different layers and comes out with an answer. So this is the basic concept of deep learning. So you can put in the patient's LFTs, you can put in the radiology, you can put in the symptoms, and finally it'll tell you this patient has, say, enteric fever with hepatitis and so on. So this is how it actually works. This is a very simplified fashion. And for you as doctors, you have to know only three things. That the foundation model of AI is three things. First is the language model. The language models are so-called ChatGPT. This is a large language model. You can have short language models also. So everybody uses ChatGPT. What ChatGPT does is you ask a question, it goes to multiple search engines and gets an answer. So that's what it does. The second is computer vision, and this is what is endoscopists have been using for very long, like what Patrick showed you about a dog, how to identify and so on. So this is a computer, and in hepatology, it basically boils down to radiomics. Radiomics is you give an X-ray and then it makes a diagnosis based on the image and so on. The third foundation model is natural language processing, NLP. NLP normally is used that when you talk, everything is recorded in a segmented fashion. But more than that, NLP is more used now to extract information from hospital records, EHRs, EMRs, and so on. So these are all the models, and put together you have what is called a multi-model models. That is what we as we should know as a doctor practicing how this can be used. Now, what I'm going to subsequently talk is based upon the discussions I've had, many hours I spent with our Institute of Artificial Intelligence. We have a large institute now in our hospital. You can see it's headed by engineers and doctors. About 40 Google engineers are employed with us. So they give me a lot of what background is and so on, because as doctors, we don't understand so much about all this stuff. So subsequently, what I'm going to talk is based on the work they have done and the understanding I've got from them about artificial intelligence. Now, why AI in hepatology? AI in hepatology, you heard a lot of these talks. Liver diseases are complex. They're very data rich, and for AI, require a lot of data. Very often, we don't make an early diagnosis because we're missing the data. And now, I think very important, personalized therapies are coming in. You can do a lot of personalized therapies. And more important now, again, is the new drug development. Before AI came, it would take about 20 years to develop a drug. And now you can do it in 3-4 years. And I think the next 4 years are going to see hepatology where there's so many new drugs that are going to come up. We don't have to wait for long periods. So basically, this is from a review article my colleague and others had written, and you can see that use of artificial intelligence in hepatology is prime time in many areas. I shall come to more specifically into these areas. For routine clinical lab, you get a huge amount of data that can be summarized to give you what exactly is the summary of what you're going to find. Radiological based images, I'll show you examples of how it can actually change what we do. Pathology is another big area where AI is being used. And multi-omics, I think Arun just talked about multi-omics important. So there's so much of data coming in with your genomics, transcriptomics, proteomics, and so on. To synthesize all that and get together meaningful data, we require AI. And of course, for real-time monitoring and so on. So let me show you an example. For example, I think the commonest problem we see in our OPDs, our patients are coming to us with NAFLD, steatosis, and fibrosis. We know that ultrasound is a very inadequate way of diagnosing this. We are starting to use a lot of fibroscans. Unfortunately, the machines are costly. There are limitations, especially if the patient is obese and so on. So therefore, can we use AI to overcome this? And this is an AI tool that our AI department developed for early detection of fatty liver disease. What they used is 4 simple blood tests costing less than $15 for international audience. Put together along with certain other data of the patient, we can actually get data exactly like a fibroscan without having the need to do a fibroscan. Look at this. Our AI data is very closely matching. So we have validated this in 40,000 patients now. The initial discovery data was in 40,000, another 40,000 validated it, and we are now ready to get it into prime time. So practitioners in remote areas without access to fibroscan and without needing this expensive device can actually make a very accurate diagnosis of what amount of steatosis and fibrosis. Of course, there are some confounding factors like when you do the LFTs, the patient's body status and so on, but in general, this can be done very easily, okay? 94% accuracy, see that? Another example of how radiomics is being used in hepatology. This is a patient who came to me very recently, and you can see a nice lesion there. This was a HCC, which was 3 centimeters in segment 5/8. So he's been following up with me for a long time. So in fact, he had a CT scan done 1 year back, or 1.5 years back. So I told our radiologist, can you pick that up, and did we miss it? Did we get to it? This could have been picked up earlier. And we actually took this CT scan. Our radiologist saw through it and said, nothing is there. We sent it to another very top hepatic radiologist to tell us something is there because the patient was making a little fuss. Nothing was there. But when we ran it through our radiomics, look at this. It says there's an abnormal area in segment 5. Watch carefully. So if we had done this earlier, then probably we would have picked up this lesion much earlier. This made me a big fan of radiomics. I think there's something that AI is seeing that we are not seeing. I think it'll take a long time for human eye to pick up what AI is picking up. So I think this is an area where there's going to be huge progress. So we can predict, I think, fibrosis, progress, MELD score enhancement. I think Patrick just told you about that. And of course, predicting decompensation in cirrhosis, all this can be done. And histopathology. I think one of the problems with liver histopathology is there's a lot of inter-observer variation, sampling errors, ill-defined definitions, and so on. I think in this area, again, AI can stabilize, and again, experience from our pathology department, Dr. Anuradha says that she's run a huge program now where doing a multicentric study, they have been able to stabilize the definitions and so on and get fairly accurate results. I think treatment planning is again where AI, personalized medicine, stratify patients for liver transplant, predicting response to cancer immunotherapy is going to be next future because you have so much of data there. You have data with which you're sometimes very confused, but using AI, you can predict patients' response and tell antiviral therapy. The other very interesting thing is that in patients who are coming to us with liver disease, of course, the problem is, one is the liver disease itself, which can affect drug therapy. You have drug-drug interaction, you have drug-liver-drug interaction, so many factors. And as clinicians, we never see any of this. We just say, this is the diuretic you must take IV albumin and so on. It's a very interesting study that our Department of Genomics, along with AI, have done. What they did is they took the data of 2,000 patients, many of them having chronic liver disease, and doing a pharmacogenomics, drug-drug interaction, drug-liver interaction, to see what was our prescription patterns, whether they were right. And what was surprising is that in 30% of the patients, our prescription was wrong. Patients who required a diuretic maybe once in 2 days were given once daily. There was a lot of interactions which, with human intelligence, we can't make out on a clinical output. This is a paper that's coming out where we showed that using AI, our prescription pattern improves. So now what we've done is in our hospital, every patient requiring more than 4 drugs goes through this pharmacogenomic pathway, and then it tells us, look, this is how the prescription should be. I think all of us, as doctors, clinicians, we are not prescribing right. We are prescribing wrong when you look at data like this coming in. And I think here AI is making a huge difference. AI is also used new therapeutic targets. We can predict drug toxicity, and this is very important. A lot of antituberculous drugs that are being used in our country, we never know which patient comes up with drug-induced hepatitis, and now with AI modeling, you can actually predict which patient is likely to get, and of course, optimize our drug dosage. And this is something that Patrick talked on, very interesting. There's actually now a cross-organ biomarkers for systemic liver disease, and based on what you see on ECG or what you see in, say, retina, you can actually predict liver disease. And this is some very interesting. In fact, a year back, Patrick drew my attention to this. We looked at this very carefully, and then I think some of this data Patrick has already shown. I won't go into the details, but I think based upon this A score, we can actually predict several things in chronic liver disease, prognosis, need for transplantation, and so on. And this is based on looking at ECG. Anybody, I think, can do this very easily. If you look at, we gave this to AI department engineers, they said very easy, and they could develop this algorithm very fast. And Patrick showed this very nicely, how you can differentiate between compensated, decompensated, know which patients are going to survive, which patients require transplant. All these are very well known now based on these papers that came from Mayo. But there's one more interesting thing here. In fact, when our AI department, Kinjal was very excited when he saw this data. He said, okay, let me look at this. So he took 70,000 ECGs from a data set in Harvard, developed this model, and got a 95% accuracy on predicting what these patients have based on this data set. And then he took 70,000 ECGs from our hospital and actually run it in our patients to see what type of liver disease they have and so on. The accuracy was 4%, which means that all these data have an ethnic bias towards so many things. So each geographical area, I think we should develop our own data. Otherwise, we depend on data that came, for example, from the Mayo Clinic. Caucasian population may not apply at all to our population. So this is an important lesson that we learned. Of course, retina and from the eye, you can see several things. And this has been going on for very long. Our ophthalmologists have been telling us for very long, in fact, cautioning us sometimes against the type of liver disease this patient can have. I think this is another very interesting area. The future, of course, is, I think Arun touched on this, integration of multi-omics with AI, real-time clinical decision tools, so that as you're looking at the patient, feeding the data on your clinic, you say that it tells you, look, this is the right prescription for this patient. And digital twins, very, very important. Again, Patrick emphasized on this. We are going to get digital twins. Very often you're going to use them. The diabetologists have used this very extensively, very successfully, and I think we should do this. But there is a fear for hepatologists. Are they going to run out of business? For example, this is a future where a patient comes through the hospital, goes through, gets all his tests done, and he doesn't require hepatologist. The attendant in the outpatient will tell him, okay, this is the problem you have. He goes back, get all the precision medicine done. It tells you this is the problem you have, and most of the time it's lifestyle changes that can help these patients, and he goes on, he's monitored with all these devices, and then he's okay. So are we going to get out of business? I'm not sure. But I think there are several challenges when trying to apply AI. One is, of course, the data quality. It's very, very important. You feed in, it's called the CISO syndrome. If you feed in wrong data, you get out wrong reports. So therefore, I think the quality of data is very important. And as doctors, this is something that our AI engineers keep emphasizing. Unless you put in the right, very high quality data, you're not going to get out good results. There's a biases that I told you about. Sometimes AI can hallucinate, give you totally wrong area. And regulation and ethics. This is another big problem. Even in advanced countries, they don't have regulations for this. There's no regulations. And what if AI gives you a wrong diagnosis? Is AI responsible or the doctor responsible? So the ethical things are involved, which I think we're still not resolved. AI predictions can, of course, go wrong. You know this very famous person who said that self-driving cars are going to come in 2 years, and they haven't come still. This was in 2015. A famous radiologist said that radiologists are going to be absolute in 5 years, but 2025, radiologists in AIG are still driving their cars, coming to work and reporting from there. So this is still uncertainties. But remember, also very important, look at this, 2009 in the United States, the traffic, they will telling us as you're driving, and this NHS got so much traffic, take another route and so on. All this was done by a pilot with a camera. In 2019, 10 years later, this changed because drones came in. Now it's all drone controlled. So in 10 years, both the camera and the pilot both lost their jobs. So this is a danger that sometimes can occur. So, but the danger for us is that we're not taking AI enough. In fact, this is a survey of EASL in 2024. There were 1,894 papers that were taken as abstracts or oral presentation. Only 66 of them AI, of only 6 were oral presentations. So therefore, the feeling is, at least in the AI world, that we're not taking it up well. We have to, because there's a fear, and this is a fear that some of our younger doctors, when we started putting a lot of AI into a hospital, were telling us that, is it okay? Are we going to lose the job? I tell them that AI won't replace you, but someone empowered with AI will. So all of us, I think, have to get a basic knowledge of AI, because AI, of course, is never going to replace clinical medicine. But clinicians with AI are going to be superior with clinicians who don't know AI. That's very important. So, and I'd like to end with what Charles Darwin famously said, it's not the strongest of the species that survives, not the most intelligent, but the one most responsive to change. And I think, ladies and gentlemen, it's time now we change, both as gastroenterologists, hepatologists, adapt some of these very interesting AI-aided techniques that are coming in. And I'm sure that in the next 5 years, there are many, many more. Our practice will change, but we have to adapt to this. Thank you very much.
Thank you very much, sir. Your lecture has beautifully demonstrated how innovation and artificial intelligence are shaping the future of hepatology and clinical medicine. We sincerely appreciate your valuable time and your inspiring presentation. Now I request Dr. Sangram Biradar sir to kindly come forward and accept the memento on behalf of Dr. Nageshwar Reddy sir. Thank you, sir. Moving on to the next session, the topic is role of semaglutide in obesity and MASLD. It is my privilege to introduce Dr. Naveen Polavarpu, sir. Before we proceed further, let us invite the chairpersons for this session, Dr. Manjunath Uncle, sir, Dr. Santosh, sir, Dr. Ravikumar, sir, Dr. Mahesh Hakke, sir, Dr. Anil Namoshi, sir, Dr. Manjunath Hatte, sir, Dr. Satish Kinagi, sir, Dr. Chennamma, ma'am, and Dr. Sharan Nandyal, sir.
So good morning and good afternoon, everyone, actually. Thanks to Shivant Patil, Nagaraj Kotle, and Srinath Patil, and all other colleague gastroenterologists who are close friends of mine who invited me for this talk about semaglutide and the other drugs which we're going to discuss. I think few drugs have already been discussed by the stalwart speakers prior to my talk. So I'll briefly take you through a few of the slides. There will be some repetition. So I'll skip the slides which have got repetitions, but I'll concentrate on the slides which we have not spoken yet. Oh, this is not moving. It's not working. Yeah, it's working. So I'll do a brief introduction about the MASH and why the topic has changed from NASH to MASH, and also brief introduction about the semaglutide and also the resmetirom and other new drugs which are coming up. Where do they actually come into the pipeline, particularly looking at the guidelines as well? Okay. I put this slide in most of my presentations just to highlight that if you look at the age-adjusted mortality of all the conditions, be it blood cancers or cardiovascular diseases, strokes, over the years, age-adjusted mortality has been coming down But the only disease which is on the rise these days is the liver diseases. Liver cancer is the fastest growing in the cancer right now in the world. And that is because of the majority of the reasons is because of alcohol, obviously, but also the NASH or the MASH is taking up quite significantly. We're seeing huge number of patients with MASH which are progressing towards cirrhosis. And we know cirrhosis is a progressive and irreversible and a permanent condition. So once you have a patient with cirrhosis in your clinic, that means this patient has got permanent damage and is only going to progress, is never going to reverse back. Okay, up to early fibrosis, you can reverse with medications and with lifestyle modifications, but once they reach the stage of cirrhosis, it's a permanent damage. So I think it's very important to understand that, cirrhosis is progressing and we're seeing fast the liver disease rising at a significant alarming state. And India being the diabetic capital of the world, we're seeing huge number of patients with the MASH leading to cirrhosis. And just put this cartoon to just highlight, it took millions of years for us to evolve from our ancestors. But unfortunately, this is what we're seeing these days with our lifestyle and dietary changes. We're seeing, all these risk factors which are developing quite significantly. Now, how big is this problem? We have already alluded before as well that the patients with MASH or the MASLD we talk about is on a significant rise, particularly in patients with diabetes mellitus. We're seeing almost 65 to 70% of our diabetic population having this risk group of having the MASLD. And if you see year on year also, there's been a significant